to an approach of examining patients presenting with low back pain and potentially hip pain as well. Um, Having already gone through the assumptions for the cervical talk, I'll just move forward. But basically, I'm hoping that you know how to do the tests already. For today is just to review the tests as well as sort of how to interpret them in a systematic way so that we can guide workup and investigations. So again, I always start again with range of motion. And again, if it's a fixed range of motion, I start to think of a rheumatologic condition. If it's not fixed, then I start to get a sense of whether or not, why is that limited? Is the patient not trying? Could there potentially be pain? It allows me to continue the exam, but sort of consider the fact there could be a mechanical issue underlying this. So forward flexion, extension, side bending, this is an example of a patient that's having difficulty moving forward. Chest expansion would be important to measure. It's a restricted people inflammatory condition, as is side bending. This is an example of the Schober's test. And so if it's less than 5 centimeter excursion with forward flexion, then you could potentially be looking at someone with an inflammatory condition. I then also want to look to see whether or not there could be a sense that this could be a non-organic issue. I know Gordon Waddell had written a lot about people that don't necessarily do well if some of these signs are present. If that's the case, it doesn't necessarily suggest to me that the patient is faking per se, but it certainly broadens the way that I would approach this with interventions such as injections and surgery not necessarily being at the top of my list. So in general, what I'm looking for is to see whether or not there's exaggerated pain behavior. Pushing down on the head or shoulders or having difficulty with rotation for someone who comes in with a low back issue is unlikely. If they have a diffuse sensory loss that's not in one specific distribution, or give way weakness in a number of areas that doesn't fit a specific myotomal distribution, pain to very light palpation in multiple areas of the body that's exceeding a specific anatomic region, all those things could potentially be signs that a patient may have a non-organic illness or centralization of pain, which is important to consider for patients presenting with low back pain. And then just like the cervical spine, I want to make sure that the patient doesn't have any central nervous system issues. And of course, looking for a vascular issue, especially for people that could have vascular claudication, I think is important. So again, hyperreflexia, Hoffman's test, positive thumb movement. I'm looking to see if there's a thoracic sensory loss, hyperreflexia at the knee and at the foot, clonus, upgoing toe, pedal pulse, and cap refill. So if any of those things are present, it makes me wonder whether I'm dealing with a neurovascular issue. And again, just like in the cervical spine, what we want to do is trying to come up with an approach to get a sense of what's happening in the peripheral nervous system if we think that there's a disorder. Again, selecting two muscles from a particular set of nerve roots will help distinguish whether or not you're dealing with a monoperipheral neuropathy or peripheral mononeuropathy, such as a femoral neuropathy, an obturator neuropathy, or SADAC issue, versus specifically whether the problem is coming from the plexus or a nerve root. And so at the L3-4 level, I generally use quadriceps, which is knee extension, hip adductors, which are hip adduction. For the L5 level, I'm using hip abduction, which is the gluteus medius and minimus, and then I'm also using extensor hallucis longus. And for the S1 level, there's a few different things that you can use, but gluteus maximus, so that's hip extension, and then one of either the gastroc soleus, although that's a very powerful muscle to test manually, and the flexor digitorum longus, which is great toe flexion, which is generally very easy to test when someone's sitting at the bedside. So again, what you want to get a sense of is whether or not you're dealing with weakness and sensory loss in a specific distribution. So if they're having difficulty with knee extension, they have a hip adduction, a knee reflex loss, and a decreased sensation in the L4 distribution, it's most likely that they have nerve root compression at the L3 or L4 level. And so we're trying to put that all together. On the other hand, if it's only weakness in one area, such as reflex loss for the for the knee extensors and weakness of the quadriceps with decreased sensation outside of just one particular distribution, then you may be considering dealing with just a femoral neuropathy. So again, let's go back for a sec. So this is knee extension, hip adduction, the obturator. So that's L3, L4. That's hip abduction, toe extension, and dorsiflexion toe extension, which are L5. S1, which is hip extension, toe flexion, and then certainly you can try plantar flexion, which is gastroc as well, and those are S1 muscles. So once I have looked at range of motion to rule out rheumatologic issues, I looked for central nervous system disorders. I looked for a peripheral nervous system disorder to see whether or not I could localize a bit better. If none of those things are there, then one looking to see is whether or not the pain could be coming from another regional issue in and around the hip region. And so basically, I want to look for internal rotation, especially when I'm examining the hip, to see whether or not there could be something going on inside the joint, such as arthritis or labral tear, depending on the clinical situation. I want to do my SI joint test to see whether or not that could potentially be another cause of pain, as well as a place that I could potentially intervene with injections. And then there's a condition called athletic pubalgia. And so the idea is whether or not someone presenting with sort of more abdominal groin region discomfort, whether or not that could potentially be one of the causes. And certainly there's a number of sub causes depending on what you find on clinical exam and how the patient presents. But this is certainly worked out differently. So we've already done a straight leg raise. I'll just stop the video there. With the patient in a sitting position when we did knee extension testing. But this is a lying straight leg raise, which is sort of that's the more formal way to test for whether someone has nerve root compression or dural tension in their back. And then from there, I go into the hip range of motion. So this is internal rotation, external rotation. This is the Faber test, one of the SI joint testing tests, SI joint loading. And those are the general things that I do from a movement standpoint. In terms of the palpatory exam for athletic pubalgia, you'll see that in the next slide. So basically then, once I think this is a mechanical issue in the low back, I try to get a sense, low back or hip, I just get a sense of whether or not I can localize a bit better to a particular region, which is probably fair at best, but it certainly gives me a better sense once I've ruled out the other things of what I could be looking for in terms of intervention, workup, and specifically injections. So along the rectus abdominis into the pubis, along the obliques into the pubis. I'm looking in the psoas area. Hernias can sit there as well. The adductor tendon into the pubis on both sides. Over the greater trochanter. In the paraspinal muscles. Over the PSIS as well, and then now the gluteal areas in the ischium region. So again, once I've established there's not a rheumatologic condition or central nervous system disorder by looking at range of motion in the neurologic exam, if I feel that someone has mechanical back pain, and some of the sub-considerations are myofascial pain, facet region pain, SI joint pain, things that I can do, I can inject top bands or trigger points. I can inject, do facet region procedures, SI joints, or even epidurals, although the use of epidurals in general is controversial, but particularly controversial in the use of people with mechanical low back pain. If I think that someone has a nerve root compression, certainly I can consider an epidural. I do a lot of caudal epidurals in the clinic where I work, and if that fails, then I have the option of potentially doing a transforaminal epidural, steroid injection, or nerve root block before I refer the patient on if they fail. And then certainly if I think it's a hip issue, I want to test the idea that it is, I can certainly inject the joint with freezing and or other things. If I think it's a tendon issue, from an injection standpoint, one of the tools I have available is a fenestration, but certainly that's not the only approach. In people that have gluteal pain, I think it's coming from the piriformis muscle itself without actually causing compression of the sciatic nerve, then I could potentially inject that under ultrasound. And then with athletic pubalgia, it's a bit esoteric about how to manage it, but certainly from an injection standpoint, you can inject the pubis or do an ilioinguinal nerve root block, and that can sometimes be helpful for patients as well. So I think I will end my presentation there. I'd be happy to answer any questions for you.